Hi, Kate. I see we already have some people here, which is totally great. They're overachieving, but I just want to make sure that we have, are you with me?
I can hear you, Joanne. You sound great.
Good. I don't think so. Let me see here. I don't think that I will be keeping my camera on for the full time because I know that we want to record this and I can't stand it. I really can't. Can't stand seeing myself and nobody else really, we don't need it. So I wanted to see what it looked like with my notes here. And also, Katie, can we play music? I don't know. I feel like, is Katie here?
I don't think it'll let us do both. So play music and show the PowerPoint. So if we want to just play music until we need to show the screen, we can probably do that, but I don't think it'll let us do both at the same time.
Rachel figured it out.
Were we on Zoom then though? I think it was WebEx.
Oh no, but that was so good, that music.
I know, I was getting down.
It really sets the tone. I heard it. Hi, everyone. Good morning. Welcome to the download. We had a lot of people who wanted to be here. So I will give us 2 more minutes. We had about 185 people who wanted to be with us this morning because we are popular. It's either because we're very popular or because people don't know what we do. But either way, I think this is going to be, I hope that this will be worth your time. And I just want to really ask you, if you're here, please be here with us. Your time is valuable. It is your most precious commodity. I really want to thank you for sharing it with us. But if you're going to be here, engage with me, challenge me, like in a nice way. Ask questions. Please just make this as useful for you as possible. I'm going to not show, so I'm a person and you can see me, which is great, but I am going to soon not be showing you me. But I don't think it will take away from the discussion. I don't know, maybe it's better, but I'm going away. There we go. Okay. I can't really see. Katie, do we have like critical mass at this point?
We're at 95, Joanne.
Okay, so we'll give it 1 more minute and then we're gonna start here. Feel free to use the chat. I'm going to have people monitoring the chat for me. Feel free to full on interrupt me. I do it to people all the time. It's because I feel passionate, because I must have these questions answered. And I know that feeling, and I think you should interrupt me. That's the way it's going to go on the download. Oh, thanks, Kate. That's nice. We're setting the tone here. "30 more seconds. Welcome to the 102 of you for joining us today. We had about 185 who wanted to, but not to worry, we're recording. We will send out the slides. Everyone always asks that. Will you send the slides? Yeah, sure. But the slides, you know, we can also send the recording, but then who goes back and looks at the recording? We'll give you whatever you want is the point. Good morning. You are at MiHIN's The Download, a monthly webinar diving into the intersection of healthcare and technology. Thank you for being here. Next slide. Okay, perhaps you've seen this before if you've joined us. I showed this at the beginning of all of my stakeholder engagements. Just to level set, we are MiHIN. We are a nonprofit organization providing technological services to connect disparate healthcare sectors and care sectors, our stakeholders, to securely, legally, and technically share health information. And we're going to get into this today. Remember, please, that we are an unbiased data trustee. Remember that we exist to advance care and better outcomes at lower costs. But most importantly, I think for me, as you are here with in a stakeholder engagement, stakeholder capacity, technology is supposed to be a tool that supports human beings. I am all about human infrastructure. Technical infrastructure is super important. 2, I don't personally do it, but from my perspective, and this whole thing is from my perspective, as you'll see, my perspective is that humans are the energy. We are here to support humanity, and that technology is supposed to support the ability to connect, communicate, and collaborate. That is MiHIN, and that's our network. Next slide, please. Oh, look, today's agenda. There will be a welcome by Joanne Jarvie. There will be a MiHIN 101 by Joanne Jarvie. We will then adjourn, so says Joanne Jarvie. Who's Joanne Jarvie? Next slide. Hi, I'm Joanne Jarvie. I'm turning off my camera because we're recording and I'm really distracting, truthfully. So I'm going to turn off my camera. So here's what you should know. I am the Senior Director of Outreach and Market Communications at MiHIN. I made MiHIN hire me. I really made them hire me. I wanted to understand, like you all, why I kept landing at their doorstep. I was working for a community-based organization. My job was to create sustainable strategies for social care. And I was landing at the doorstep of MiHIN over and over and over again. I am here, my job here is to communicate our value. It is to take in our stakeholders. And I want to elevate that, I think communication is critical. And even if it may be simple, right? Communication involves at least one sender of a message and at least one recipient of a message. Communication is complex. And data is not always communicative. We are here today to learn about the why, who, how, what, where we're going of MiHIN. And you are going to be seeing it, I'm sorry, like hang up now, but you're going to be seeing it from the human infrastructure lens. Bits and Bytes, our other stakeholder engagement, will get into here the various technical infrastructure, our various tools, services, and use cases. But for today, we are going human infrastructure and we're going big picture. Next slide, please. So I have to just lay this out again. Here, we're going to start with the why. And then we are going to work our way around what the group development model says is the way that human beings collaborate. And I want to give a quick shout out to our partners at Michigan Health Endowment Fund and MPHI, who granted me and granted us a training in this group development model. And I use it all the time. And we are going to use it as a structure for our engagement today. Let's start with the why. Why? What is MiHIN's why? Why do people come and work for MiHIN? Why should people work with MiHIN? Well, there is such a thing as data for good. Gartner Technologies is a research and consulting firm, and it defines data for good as a movement in which people and organizations transcend organizational boundaries to use data to improve society. Okay, so if you're looking for a why, I think that the United Nations Sustainable Development Goals here is a good place to start. And if I look closely at this, I would say MiHIN's got a few whys on this list, starting most importantly with number 3. It is why for good health. We can kind of tap in though also. Why? I don't know, for innovation and infrastructure, number 9. Why for number 10, reduced inequalities. Maybe there's a why here if the technology works well and if we implement systems that are fair, potentially we could solve for hunger. Or maybe we can start redistributing wealth for poverty. But we're going to start here, the why. Our why is good health. Next slide, please. So why does MiHIN exist? MiHIN evolved as a solution to the data silos that emerged among hospitals and health systems and the variety of electronic health record software that they implemented to provide. So this is our what? A shared necessary technology and infrastructure for the secure, private, legal, digital exchange of clinical data. That is the what. The why is to help improve the health of Michigan's people. Inefficient care delivery, when doctors don't talk to one another, results in a lot of money in wasteful spending every year. As a result of these inefficient care delivery systems, patients can receive repetitive tests, health and complications, they die. Nationally, an estimated 251,454 people die annually from medical errors, and adjusted for Michigan, which is 3.09% of the population, that's 7,768 people a year that die from medical errors, which is over 8 times the people that die from car crashes. Many medical errors are caused by administrative complexity and exacerbated by the problems of health information technology. There is dissonance here. There is waste in the forms of excessive and redundant administrative burden, HIT usability and interoperability deficiencies, failures of care, over-treatment. I mean, in other words, an estimated $19.8 billion a year, or approximately 4.7% of Michigan state domestic product, could be used more efficiently. So why were we created? Why are we here? Next slide. To solve for a lack of coordinated care and efficient systems, and to support a streamlined delivery of care to improve health outcomes. Does anybody have any feedback there? I don't know if you remember, but on the slide, for us to collaborate and us to engage, there has to be constant feedback. Does anybody have questions thus far? And also, I'm not going to keep asking if you have questions. Like, I feel like you should just interrupt me. Thanks. Next slide. Look, government, civil society, all industries, all sector are just beginning to understand the value of data to society. Sort of in the same way, we considered the importance of roads 200 years ago, or power lines. And just as these roads and power lines, that infrastructure ushered in a new era of energy and helped society thrive, we need investment, time, energy, collaboration, and focus to support modern approaches to data infrastructure. This will, it will enhance economic growth and innovation, but more importantly, it should support individual health and wellness and protect us from harm. No matter where you are in your organization, no matter what you do for your job, the opportunity to create more responsible technology and a more responsible tech future is massive. And MiHIN doesn't take this lightly. And frankly, the healthcare sector, with its health information technology exchange rules and regulations, also doesn't take it lightly. I wish there was a MiHIN for the data that is being captured on social media. I wish there was a MiHIN for the data that's captured on the internet. For technology to truly work in public interest, we need to invest in building organizations that are free from corporate profit motives and that respect and work to integrate, incentivize, compensate, coordinate, and coordinate disparate sectors with whom they work. We need organizations that exist in the middle. Next slide, please. In the middle of what? Well, in the middle of different sectors, in the middle of different organizations. In the middle with different people. So what's our who? That was our why. But who do we do this for and with? And who are we governed by? So this is an interesting slide here. If you take some, I don't know if you guys can see it. I hope you can. Thumbs up if you can. But this breaks down the tiers of stakeholders for a health information exchange. Okay, it goes macro, meso, micro. And these are our stakeholders. Okay, these are MiHIN stakeholders. This is our for whom and our with whom and our by whom. A stakeholder is a party that has interest in a company that can either affect or be affected by its business. Our stakeholders, next slide please, are healthcare stakeholders. They are the people of Michigan, anyone who's a patient, directly as we roll out consent and increasingly getting data out to people related to public health support. In the future, as social determinants of health are tracked, are screened, are used, we will be sharing, we hope to share more useful information legally and technically and privately to support the people of Michigan. Health professionals, of course, physicians, nurse practitioners, physicians assistants, nurses, respiratory therapists, dentists, pharmacists, occupational therapists, physical and behavioral therapists, as well as allied health professionals such as phlebotomists, medical laboratory scientists, dietitians, social workers, our customers, our stakeholders, healthcare facilities, hospitals, long-term facilities, emergency departments, state government. The Michigan Department of Health and Human Services is our main customer today. State agencies, their departments like corrections, right? Or the Department of Education, Department of Licensing and Regulatory Affairs will be increasingly more important. Health payers, insurance companies, organizations like prepaid health insurance plans, Priority Health, Blue Cross Health, Medicaid managed care plans, pre-patient inpatient healthcare plans. Let's not forget counties, cities, as we do more with county governments through public health, but also emergency medical services, county jails, local health departments, local social work, foster care, homeless shelters. These are our for whom, with whom, by whom. So yeah, thanks, Katie. You were right. I want to give you, we're going to start here. We're not going to move through this. But what's important here, we're still on the who, guys. We're still on the who. So what's important here is that the Federal Office of the National Coordinator, ONC, established State Health Information Exchange Cooperative Agreement Program. Okay, that was in around 2010. And then to set priorities for the state and to provide for a degree of oversight, Michigan legislators created a Health IT Commission with members appointed by the governor. Fun fact, I wrote to the governor, like before I got my job at MiHIN, to suggest that I join the Health IT Commission. I haven't heard back from her. I'm still waiting, but the Health IT Commission, write your letters, go sit on it. The commission recommendations led the Department of Health and Human Services, that's MDHHS, to select MiHIN as the state designated entity for health information. I think you're going to be able to move forward on this slide, Katie, if you would. Our model seeks a careful balance between state government input and private enterprise. MiHIN appoints a board member for each of Medicaid, the Department of Health, and the Health IT Commission. This approach relies on governance rather than regulation to ensure patient privacy is protected and that the network is operating in a trustworthy manner. We have a Michigan Operations Advisory Committee, which I am lucky enough to facilitate, that reports up to our executive leadership. And you can see how our governance is structured. This is the by whom, by who. Any questions? Oh, I said I wasn't going to ask you if you had any questions. All right, so let me just give you a quick bit of history that is going to transition us from the who to the how. So the state promoted the early growth of HIEs by encouraging local organizations to form throughout the state. Next slide, please. 9 HIEs operated in various medical training areas with the assumption that competition would lead to innovation and consolidation. Michigan subsequently formalized MiHIN, a nonprofit organization, as the state designated HIE to coordinate among these medical training areas. Next slide. Having started by orchestrating small regional HIEs, Michigan today engages with MiHIN as a consolidated statewide public-private partnership. Next slide. That's the where we're going, and we're going to catch up on that in a bit. Next slide, please. So how? Why? Who? How? For Michigan, a careful balance of state engagement and private enterprise, starting with the many small HIEs and evolving to one, has produced an infrastructure which I would describe today as capable and innovative. By sending and receiving patient health information from many different EHRs, so that a primary care practice, emergency department, pharmacy, health insurance company, or public health program can quickly access and share critical health data in real time, MiHIN operates as an information hub that can send and receive clinical data from a range of EHRs used by different hospitals, clinics, and healthcare providers and payers. The more EHRs connected to our HIE, the more information they can access, creating greater value for our participants. Next slide. The collection of data can also offer insights into population-wide health trends for greater public health awareness and more effective health monitoring and resource allocation. Rather than making technology the starting point, Michigan's approach to health information exchange focuses on the purposes for which the data will be exchanged, the why, and the policies and incentives on a case-by-case basis for making that happen. In Michigan, healthcare providers are financially incentivized by some health plans to contribute data on a use case basis. Next slide, please. The goal is to achieve a shared understanding of activities that our infrastructure must support, including defining the value, the benefit, and the priority of each activity. The MiHIN Use Case Factory fosters and motivates the statewide alignment to advance a portfolio of use cases that employ national interoperability standards. The purpose of each use case is to help ensure that the right services and activities emerge statewide that lead to reducing complexity and ensure fewer errors in confidential ways that generate greater customer service to multiple MiHIN stakeholders. It is a formal, thanks, Kate. Moving on. The Use Case Factory is a formal methodology to modularize, prioritize, define, and advance data sharing on a large scale. It consists of a standardized approach to managing the full life cycle of a portfolio of data sharing using use case scenarios and the associated governance process to prioritize and motivate their adoption. Next slide. Look, a nonprofit needs enterprising spirit and strategies for sustainability. Through affiliations and related companies, MiHIN is part of a growing multi-state HIE model. Our team offers consulting to out-of-state HIEs and through the the consulting is through Bellator Services, as you'll see in the next slide. Through Interoperability Institute, we prepare scores and scores of interns every year for work in the health IT field post-graduation. Shout out to my interns who come to MiHIN with a ton of interest even outside of the healthcare sector, which I think is fabulous. MiHIN makes money using a diversified revenue model. How do we still exist? It's our diversified revenue model. We get paid by our stakeholders for some of our tools and services. Some organizations generally derive value from providers sharing, and they also have limited resources. And we understand this and have built this into our business model. Typically, health plans pay us for subscriptions to use cases and key services. Some health plans have begun to purchase our tools. The state of Michigan subscribes to use cases, services, and tools, but also engages MiHIN for a variety of hourly projects. Finally, Bellatura hires MiHIN to provide our products and strategies to other states or geographies. Oh, that's our how. We've made it to the what. This may be like what you're most interested in, but you're going to have to come back for bits and bytes if you want to dig in. Here's our what. Our use cases determine the services, and our services are operationalized by our tools. We will always offer a tool that promotes a use case or service. We will send data, however, to any vendor that a provider in our state asks us to send that data to. These are our MiHIN use cases. Does anybody have any questions regarding our MiHIN use cases? Should I leave this up a little bit longer? Is anybody really there?
How do you standardize all the data?
How do we standardize all the data? Okay, well, let's go through the services and then the tools, and then we'll get to that. MiHIN services, ADT normalization and conformance, CCDA normalization and conformance. You can see that part of our work is to standardize. These are the services that are provided, that the use cases gave rise to. These are the ways in which we provide for health information exchange. And these are our tools.
That he came up with, because we needed it for this, and then I altered it.
Ah, I'm hearing somebody. I don't know if you're talking to me. Okay.
This is Hope Whitaker from Dickinson and the UP. I guess my question is, I mean, I see that we have a two-way interface from looking at it to care quality and to the Commonwealth, but is there going to be an easier way, having to log into the gateway, and search for the patient? For those of us that have the smaller EMRs like Paragon, we don't have Epic, we don't have Cerner that has the integrated care everywhere. Is there going to be an easier way for providers to do this when they're seeing the patient in the office for the EMRs that don't have that availability? Just a question, because the reason they don't use it here is because it's an extra click. They have to search for the patient again.
Are you saying that the reason that are you talking about getting the information that is in my gateway into your EHR? Yes, that exactly. And because we don't have that ability, then, they have to actually look it up in the gateway and pull the patient up. And it's just another application for those of us that have many disparate systems. It causes a lot of extra work. So I have a whole team that's backing me up today. I would like to ask Mike Taylor, Megan Gibbs, guys, help me out here. Are we working for, isn't our tool to make sure that people can access our services
Yeah.
in ways that like they couldn't do through their EHR?
Well, it's not just in ways they couldn't use it through their EHR. It's to ensure that there is a way to use the service if your EHR is not an option. If cost is a barrier to integrating with your EHR, or if it's a functionality that your EHR doesn't offer, we have tools to kind of make a ground level floor so that everyone can make use of the information in some capacity, no matter what.
Correct. And it is a wonderful tool. It's just more time consuming for the providers. So in the clinics, they're using it because they have other people helping them, but it's just very different. You know, it's very different in the inpatient setting. So for those of us that don't have the EMRs, that don't integrate, like Epic has Care Everywhere, I don't know what Cerner has, but those of us that have the systems that don't have that integration, it's great, but it is extra time, and inpatient is just not using it like outpatient does. So I'm done, Joanne. That was it.
Yeah, Hope, let's get back. Hold on, we're going to get back to you. I'm going to move us forward, and then we're going to go into the chat because people are finally engaging. But also, I want to get back to this, Hope, because I think it's touching on something. There's dissonance. Kate, let's move forward, and then we will come back. Here's a slide. This is a slide of our cumulative quarterly message totals from today. I wanted to talk about where we're going. Where is not on the, where is not on the model of going around the circle, but it is important for our how, and it's important for our what. This is from the Michigan Health IT Roadmap. These are priorities, therefore, of MiHIN and of health information exchange in the state. Followed by Kate, nationally, where the ONC and federal government wants to go. So these are the highest level priorities. I think what we're going to find in the chat and what we're going to find in our discussion today are the micro and meso level priorities, not macro. So we're here. Are you interested in working with MiHIN? The first step is to identify a use case. Why? Your why. Why do you want to share the data? What's it going to be used for? From there, we'll work together to identify policy or governance challenges or opportunities and figure out how to create technological solutions to enable that data sharing. That's the story of MiHIN. That's our why, who, how, and what broken down into a half an hour. I'd like to ask, if I could, for my team, Mike, Megan, Katie, Stephanie, can you come on to screen with me and let's start working through our dynamic discussions. Let's start working through these questions. Are use cases more specific, Robin asks, for different users? Some that are more useful for providers or hospitals or health departments or government organizations. And is this easy to see and understand from your website? This is not easy to see and understand from our website, but it will be. Check back in like 2 weeks. But the use cases in general, just so that you understand, the use cases are written generally. They are not written. They are not written for specific users. Am I right about that, Megan?
Yeah, I definitely think so. Everybody, I think, kind of has this perception that maybe this specific use case may be tailored more to a hospital or provider, but you're right. We write them generally so it covers a large population where there's value in exchanging that data regardless of, what sort of healthcare professional status you may carry.
And I have to say that like organizing the use cases and the services by specific value by customer is exactly why I started to work here. So look, in a month, if we can't figure it out, no, we will. And I'd love your help. I'd love to learn what's working for you. I'd love to hear more about how you use our data, how you use the data exchange, how you use the network, how you want to use the network. Currently, says Adam Stevens, we look at one patient at a time through our HIE Viper. Is there or will there be the functionality to look at more complete data for the totality of the people we serve? For example, the ability to export a spreadsheet with all or certain lab results for our people. Is this an operational like thing that we can do in my gateway? Can you get all of your patients' data out?
So currently that information is available similar to the way it's available in Viper, sort of at the patient level. But I will say one of the things that we're working on in terms of leveraging sort of like the future states of acres is the ability to be able to generate or to be able to pull at a population level information about those patients, and then ultimately to sort of tie that to whatever downstream information you're looking for. So it's not something we can do today, but it is something we're definitely working through and considering moving forward.
And for those of you who don't know what ACRES means, ACRES is an acronym and an acronym. Don't you love those? For Active Care Relationship Service. This is MiHIN's patient context and patient matching service. And so I think what James was saying, if I can break it down into like, layman's terms, human infrastructure terms, is that by using ACRES to connect attributes to a patient, you would be able to see which patients are your patients and then segment the data by that. So it's coming. And if it's something that you want sooner rather than later, let's incentivize it. Let's make it happen. How many other people need it? How many other organizations want to do this? There's a need to have bi-directional interface so the patient info flows both ways without searching another source. The EHR should be the single source of truth. Should the EHR be the single source of truth? And does MiHIN work to support that? Anybody?
I don't want to dominate the conversation. I was waiting to see if anybody
James,
else
can you
spoke
just
up.
dominate the conversation?
Sure. Yeah. So I think it's important to sort of talk about the fact that MiHIN definitely agrees that the bi-directional exchange is valuable and is something that we're making available. We have a solution called the Intelligent Query Broker that we've been working to make available to support bi-directional exchange more broadly in Michigan for MiHIN. And I think the goal is to understand and sort of recognize that the data that's being captured in the EHR is sort of always being captured and always being updated, and we can access that data directly when somebody needs it. That is sort of the ultimate goal. So it's definitely we have a couple or a handful of query-based exchange use cases that are working today, but they're relatively limited. And getting the intelligent query broker available in Michigan is going to expand on that quite a bit. And then so we get to a point where we can do and support a number of different query-based exchange use cases at that point.
Do we have an idea of the time frame for data sharing from out-of-state hospitals, labs? Anybody have a time frame for that? I don't know if we have a time frame for that. I know that it's the goal.
Yeah, Joanne, this is Megan. I think we can probably follow up with Adam G from a USQ-HIN perspective and see if he can get some sort of updates that we can send out to the group.
Let's see. So the e-referral for Michigan Tobacco Quit Line, Cheryl. So the tobacco quit line, if we can go back, Katie, can we go back to our use cases? Where's the tobacco referrals? Yeah, so I want to dig into this with you, Cheryl, if you wouldn't mind. I will take this as an action item after this. We actually have been getting other questions about it. When you say, do we know the status? Can you be more specific? What are you looking to do and what can't you do?
So thank you, Joanne. It's a general question. I work for Altarum. We're a nonprofit in Ann Arbor.
I know you.
Yeah. So we have a project, HH4M, and part of this initiatives that we're rolling out to the practices is for the clinicians to be able to submit the e-referral through the direct address. And so last that we knew, there were contract negotiations, or there's a break in the e-referral from MiHIN's through the direct address. And I'm sorry, I'm not a subject matter expert on exactly
Me neither, and you don't
broken.
have to apologize. But you found the right girl. Look, if there's an answer to be had, I'm going to get to the
Cool.
bottom of it.
Well, thank you.
Yes.
You're awesome. Thank you.
I feel like, there's these so the use cases have use case exchange scenarios, and the tobacco is the scenario of the referrals use case. And so I need to dig back in through the use case into the services and then the tools to find out where we are, if that makes sense.
That would be great, because it's a huge barrier now in rolling out this intervention. We thought that we would be able to use the quit line and an e-referral and set up the direct address and really streamline it, on this project. And then on other projects, the same thing. I have a behavioral health client that wants to use the e-referral system, and that's broken too. So faxing is not ideal for them, and then tracking.
It's broken.
Yeah, it's broken.
It's broken, like it worked and then it broke and it isn't fixed. And I'm just like, again, we're going to dig in here because we have tools for referrals. So we just have to, we have to get to the bottom of it, and we will.
Oh, thank you. Thank you.
Mike Taylor, you wrote something smart in the chat here. A population level poll. Oh, population level poll might not be a real-time friendly activity.
Yeah, that was back on.
Right. Yes. So like you poll population right now, you have to look up one by one. What about all of our patients? Can we get an Excel sheet or a report? We're looking to be able to do that. And we have the ability to do it through acres, but the tool needs to be able to do it.
Yeah. And all I was saying was it's possible that we could implement things like that, but I just wanted to set expectations that it's not I decide right now that I want it and I go push a button and it comes. It would have to be we set up something to run on and it would be prepared ahead of time.
So for the record, the how of health information exchange is not just a button. I'm kidding. It's not. The community health centers in the state are getting payer care gap data in their population health tool with location codes, which would indicate, this is from Cheryl. Hi, Cheryl. Oh, Cheryl, are you from MPHI? I'm unsure if these codes are payer specific or universal to a state identifier. They seem to be 5-digit location identification codes. We're just looking to see if anybody has the code breaker. All right, so look, Cheryl, again, especially for cancer screenings, we can help you here. You want to figure out what this code is, where it's coming from, why it's getting into your systems. I feel like we can help. Mike Taylor, James Nolan, am I speaking out of turn? Yes, I'm speaking out of turn.
So this is Cheryl, and I'm from MPCA, but you were close. So I think the biggest challenge is for our centers that have access to Viper, they just go in. If they see it's been done, they go into Viper, they look for it. For the centers that don't have Viper, it's like digging in a needle in a haystack. So they might have an idea of where their patients tend to go, but so somehow that payer has a location code assigned to where that, let's say, mammogram was completed.
Okay.
Somebody must have some way to connect that code to a physical location so that they can then log into patient ping or whatever other system they have access to get that data. So I'm just trying to match up
Yeah.
a code to an actual physical place.
Okay, so different use cases that we have end up using different codes. Like if you're talking about immunizations with MiHIN has its own site ID. And if you're talking about labs, they're going to have a CLIA number. In a lot of the cases for both the things I just mentioned, we could probably help you with the mapping. If we're talking about a use case that MiHIN is the driver of the ID, we're pretty consistent in pushing the use of OIDs, object identifiers, for facilities. And we can definitely, for anyone who has executed the health provider directory use case, we can give you a report that has all the OIDs that we know about and the names that maps to.
That would be a good start. Thank you.
It's an action item. Who's taking notes? I know we have a lot of people taking notes, actually. Michelle, is there any integration with pharmacy dispensing systems currently? There would be great value for pharmacists to be able to one click and see recent labs, vitals, diagnosis, discharge summaries to avoid consuming calls or delaying prescriptions. So I know that we connect to a number of pharmacies. Can anybody on my team speak specifically, like what information is being sent and to where for the pharmacists?
Yeah, so those existing connections are mainly for reporting or for reporting immunizations or that are being performed at those pharmacies, or for immunization history and forecast, where they're looking up whether immunizations are due to be performed or have been performed recently. We're currently, at least not to my knowledge, and somebody else from the MiHIN side can correct me if I'm wrong, we're not currently interfacing with the pharmacies and around prescription data. We had in the past, that has been something that we've explored with a number of different organizations, and I think it's an area where we've identified that there would be opportunity to sort of make that data available to the larger care team, especially around like when prescriptions are actually prescribed, or are they getting regularly filled? Is there helping to identify any gaps there that we might be able to close, like by a primary care physician or by a care coordinator or care manager? But I don't think we're not currently doing that today.
Michelle, what kind of what technology does pharmacy dispensing system, like what is it, a pharmacy dispensing system technology? It's not the same as an EHR, right?
No, it's different than an EHR. So it complicates things a little bit. I don't know exactly how it works,
But
but
if
they're all
the
different companies.
pharmacists had access, so I'm gonna tie in Robert. I hear your frustration and hope too. For small clinics, or even if you have, you're saying even if you have a Viper, which is a tool of MiHIN's that came over in an affiliation, but you're saying we don't have extra staff to like go in and look for the information. So Michelle, for pharmacists, would pharmacists be able to go into another system and look for the information they need, or would they need it to show up where they're like in their system as well?
It would be much better if it would show up in the system that we're in.
So that's the thing. So right. So we're hearing like the optimal state is if you had the information in the system that you work within. And I do think that's the goal. I'm wondering, so Robert, what, our hospital is a very small, and Hope, Robert and Hope, you guys don't have, what EHRs are you working with?
This is Robert. We use Cerner Community Works, which is their cloud-based solution.
Cerner. And Hope?
We have Paragon,
Paragon.
which used to be Allscripts. Now it's Altera. They just got bought out.
Allscripts. Okay. So the question here is, and is this the larger question? Tell me if I'm getting into, look, I did this whole thing, right? I did the presentation. I hope you guys know our how, who, what, why. But is this dissonance, is this challenge here that people need our services and need the data to flow, but that the data can't flow directly into the EHR? And is it because the EHR won't let it?
From our standpoint, we're mandated to send data, so we do that, but we're so small staffed that to get it back out by going to the My Gateway or whatever is prohibitive because we don't have the time. So if the data came back, it would help us a lot.
So you're saying that like somehow you want it to be automatic, that it would come back?
Right. A true bi-directional interface. If, our patients are identified, because we send the acres file, it should automatically send the information back to us.
But it's a different service. Kate,
Yeah.
Can you go back to really quick? Just walk with me here, Robert. I need this from you. Kate, can you go back to like the beginning of our how? Because I want to, okay, so yeah, that's the one. So the services, the way it works, right, is that there's a send, receive, a find, and a use. You're saying that if you send, you should also receive.
Yes. And I'll give you a case. We're so small that we send out a lot of people to Marquette General because they're the big boys in the area.
Okay.
They do all sorts of testing, surgeries, all that kind of stuff. We find out what happens when the patient shows up and tells us, hey, I was at Marquette General and I had my, some kind of surgery and this is what the outcome was. If we had the bi-directional interface, everything Marquette General did would flow back through to us and would be in our patient's record.
Correct. And Marquette General has Paragon as well. Just putting that out there.
Yeah, but they're also switching to Cerner.
But they're switching to Cerner, yes. Mhm.
Yes.
When your patient goes to Marquette, do they don't, so it's on them to send that information?
Which doesn't happen consistently.
Okay. So what we're saying here is that in the case of getting information from another organization, that the HIE should solve for when somebody wants that information. And what James Noland, our product marketing manager, said was that we're working on something that would be query based, right? So if you send information, what, James, it would automatically query the organization for information to be sent back.
And that's essentially what we do with admission, discharge, transfer notifications, and the continuity of care documents that we get. And I apologize, I'm not sure if that's still called medication reconciliation discharge or if we updated the name of that use case. But when that information is sent to MiHIN, we do run that up against our active care relationship service, see who has relationships with those patients, and we'll deliver that back out to people whom subscribe to get those notifications and that data. Cerner should definitely be able to ingest the ADTs. I don't know if we have a feed set up for that now, and I'm assuming that they'd be able to ingest the CCDs. I think that's part of being the meaningful use compliant part of it. So that is a feature that's available today. That medication known at discharge, that document's going to have quite a bit of information about what happened in that event. So that could go a long way towards what you're looking for if you're not receiving that information today.
We're not sending or receiving CCDs at this point because it's been cost prohibitive up until this point for us. And now it's being mandated, so we have to do it. But we had to wait until last week for Cerner to have a resource to work with us on it.
Gotcha.
When I say small, just so you have reference, our inpatient unit is 11 beds.
Yep.
And in our in the Paragon EMR, they just finally have the ability to automatically send those CCDAs. We're doing it manually at our hospital. The Hucks are doing it. It's crazy.
There's a note here from James Nolan, who didn't want to come on. Part of what we're looking at implementing around query-based exchange is aligned with what we're talking about now. We're on the right track, people. Is there interest in diving deeper into our various use cases, services, and tools? And if so, which ones? Oh, I can't hear you. I'm so sorry. If you're talking. SDOH, social determinants of health. So I'm going to dispel something right now. We have a program that was named social determinants of health. MiHIN is not responsible, nor can we solve for the social determinants of health. What we can do is operationalize cross-sector data exchange. So Mary and Harbuck Valley J, that can't be your name, or maybe it is. Is it your first name? What about social determinants of health? Is it cross-sector data exchange? Is it what data is useful or sent during screenings? How we plan to send, diagnoses around social care? What part of it is most interesting to you, or what do you need?
Well, definitely the data exchange we're talking about. I'm just starting to get involved in the project that we're doing at McLaren Physician Partners with Blue Cross Blue Shield of Michigan. But I know that we do have a data call coming up next week where we're going to do some data mapping and just go over the different data elements that are going to be exchanged with MiHIN.
Great. And are you working with, who's Megan? Megan, are you with McLaren?
I am.
So can't you get on that call?
I could. I don't know if I have the invites included. Let me put my email address in the chat and then feel free to connect with me.
Let's also, Mike Taylor, close the loop too with our social determinant of health cross-sector data exchange program to make sure that everybody knows, you know, what next steps are and what people are looking for, please. Stephen, are we looking to combine CCDA into one complete CCDA to provide to all people on a person's care team? Right, each time that a new CCDA or other data becomes available. James, talk to me about the CCDA.
I feel like this is a question that was set up for us a little bit. So we have what we call the super CCDA, and that is essentially what you're talking about, which is a longitudinal CCDA that sort of encompasses all of the different CCDAs that have been generated from different organizations for a patient for their past visits and most recent visit. That today is available through my gateway. If you're looking for information about a specific patient, it comes up on their sort of summary view. We have talked about in the past making that available for query or for sending that out as an alternative to the individual CCDAs for organizations, or in addition to the individual CCDAs that Mike was talking about previously. But we haven't started doing that yet because it hasn't been something that we've had a lot of interest in. If it's something that we want to make available or that people would find valuable, we'd love to have that conversation and figure out what we can do to get that information to more people.
Yes, let us know. You guys, it's 11:01. It has been my pleasure and my challenge to be working with you on this. Thank you for coming. I am your girl. I will get you to who you need. I bother everybody in this organization every day to create clarity around the why, the who, the how, and the what of MiHIN. Thank you for coming. Thank you for working with us. Thank you for supporting us. Have a wonderful day.